Right. Good afternoon and good morning, everyone. It's fantastic to see everyone again. The Australasian Pleural Seminars is a forum that we try to improve clinical care on pleural disease and also to stimulate research interest. I think we all agree that pleural fluid cytology is a key part of practicing pleural medicine, and a cytology that is well performed can significantly reduce the need of biopsies or thoracoscopies. So today we are very delighted to have Dr. Celia Green, who is our pathologist at Path West in Western Australia. She has got a special interest in pleural disease and pleural fluid cytology. And today she's going to teach us how to communicate with the cytologists and understand their reports, which I think is of interest to everybody. So over to you, Celia. Thank you for coming.
Thanks, Gary. Thanks for inviting me, and thanks, everyone. So today I'm going to be talking about understanding your cytology reports, slightly different titles of what Gary gave me, but I think as, kids yassify titles, I think Gary gazified my version of his. But what we'll cover essentially, the biggest thing about cytology that you hear from people is it's like tea leaves or trying to read tea leaves. But I'm going to try and convince you that hopefully it's a lot more objective than that, and you can get some real answers, not just fake futures. So not necessarily in this order. I'll talk about specimen types and the differences in expectations you should have from specimen types. And this won't be just pleural, this will just be generally respiratory, but I think it'll help you understand from a pleural point of view better. This ties in very tightly with reporting categories and how to understand these categories, a little bit about uncertainty and how to embrace uncertainty, and then a little bit about the hidden curriculum. So the hidden curriculum of something is something that you have to have been or done something to understand it. A little bit like I went to a funeral recently and I knew where to go and where to stand because I'd been to so many funerals before, but someone that I was with wasn't quite as aware. These hidden curriculums of just having the experience and having been there. So specimen types, you need to alter your expectations depending on where your specimen comes from. So we tend to divide specimens into exfoliative and biopsy specimens in cytology. And exfoliative specimens come from body surfaces, whereas biopsy specimens come from specimens that a needle has gone into. So exfoliative specimens in respiratory usually are sputum, BALs, pleural fluid, and even brushings kind of comes under this category. Whereas when you put a needle into a biopsy at CT ultrasound, or you do a direct FNA, or in EBUS, you're biopsying nodes, this is a separate process. So exfoliative specimens are often used as screening tests. The most famous are pap smears. And it doesn't target a specific abnormality. So a negative result does not exclude an abnormality in that way. Whereas with a biopsy, you're targeting a mass lesion or an area and you're trying to find an explanation for that. So it should give a reason for the lesion, and if it's not, it is non-diagnostic. So going along with that, the categories for the different types are different. And if you don't understand that the different categories exist and why they exist, it becomes much harder to interpret your report. So there is some repetition here, even though it looks quite busy, but in exfoliative, or particularly for you guys with pleural fluids, the biggest categories are going to be negative for malignancy. So that's as expected. There's no malignancy in there. The next thing can be a comment, whether it be lymphocytosis, eosinophilia, et cetera, et cetera. And then there's indeterminate. So basically what this means and what indeterminate should come down to is that we can see something that's there, but we don't know whether that represents a neoplastic process or a non-neoplastic process. So you have a process, but your differential includes tumor and non-tumor. So you can't call it something specific. Then we move on to atypical. So that's meaning that the atypical cells are there, but there's further investigation required, and we can't quite get to what the atypical cells represent. And then suspicious for malignancy. This is a category that's not very often used, and as a rule of thumb, 90% of these should end up being malignant at least. They should have a very high upgrade rate for malignancy. And then finally, we can say malignant cancer cells are present. So this is very different to a needle biopsy setting where the first category is non-diagnostic. So this tells you that you haven't been able to adequately explain the lesion, or you don't have enough material. Benign, so instead of negative for malignancy and saying this non-targeted fluid that would come off a body surface doesn't have any tumor in it, you're saying we've identified the process and it is benign. And then the other categories are similar, and there's no real difference from there. So non-diagnostic is the biggest category that I think people don't understand when we're talking about cytology specimens. Lots of material doesn't make something diagnostic. Context makes it diagnostic, which is why it's so important to have clinical information. I know Gary will tell you that cytologists shouldn't look at clinical information before they look at smears. I tend to agree they should do it the other way, but they still need that clinical information to make something diagnostic. If you have large amounts of benign lung in the context of a mass, that's not diagnostic because that's not giving you an answer. Normal lymph node material in the context of a large or abnormal node, that's non-diagnostic. That doesn't explain to you, why do I have a 3 centimeter node? Or a benign finding, which doesn't fit with the clinical imaging. Do you have a benign lesion, but you've got widespread metastatic disease? That's not a diagnostic sample. And then, of course, if you don't have any material, that's non-diagnostic. I think indeterminate is the other one that really causes a lot of confusion. So just to repeat, it's best used when a neoplasm versus non-neoplastic differentiation is not possible. So the example I can give that you might relate to is you have a brushing with atypical cells. These could be reactive or they could represent a low-grade neoplasm, but you can't tell morphologically which is which because the appearances are similar. Or a biopsy of an inflammatory mass, a biopsy of a mass with inflammatory cells and slightly atypical cells. It could be reactive from an infection, or you could be sitting at the edge of a neoplasm. And you need to troubleshoot on site with the radiologist for further material. And usually you're going to need a core biopsy or something like that. Now, I understand that that's not specifically for pleural cytology, but when you get into pleural cytology, indeterminate is usually because you can see that there's an atypical process, but you haven't been able to differentiate between a neoplasm or a non-neoplastic process. And finally, atypical is not as well understood. So this for us means that atypical cells are present, but we're just not sure what they represent. This can either be because they're present in very small numbers, they aren't present in the cell block for further clarification, or they're of uncertain lineage, because before you want to call something malignant, you really want to know what kind of cell type it is. So what to do next? Get more material. Don't leave the patient alone just yet. Non-diagnostic and indeterminate are similar. You need more information. Rubbish in, rubbish out. If you don't tell me something useful, I'm not going to really be able to give you something useful in response. So just closing something. All right. So pathologists love to hide, and we're a specialty that's all about hiding, but in reality, we're a specialty that's all about communication, and that communication goes both ways. So if someone does tell you indeterminate, someone does tell you atypical, someone does tell you non-diagnostic, it should be followed with a comment which can give you more information and guide you with what to do next. So if someone doesn't give you that information, you need to clarify and ask and say, what do you mean by atypical? What do you need? And this is a conversation that Gary and I have very frequently. I say, I've got these atypical cells. I don't have anything in the cell block. I can't tell whether these are reactive mesothelial cells or malignant. And he says, okay, we'll get more fluid, or is no more fluid not going to help? And do we need a biopsy? So pleural fluids, I think, are a really good example of the hidden curriculum that you have. And I think one of those big ones is a negative for malignancy characteristics. So your categories, and I think lymphocytosis is a really great one. So the differential for lymphocytosis in a pleural fluid, although the category is negative, and you can sort of move on from there, obviously you want a reason. And lymphocytosis, the differential is broad. You can see tuberculosis, mesothelioma, can be a chylous effusion. You can even really get involvement by low-grade B-cell non-Hodgkin's lymphoma. But the hidden curriculum is that recurrent unexplained lymphocytosis is a red flag, and that sarcomatoid mesothelioma doesn't shed the malignant cells into the fluid, but it does present with a lymphocytosis. And then mesothelioma in the fluid, more complex communication is required. So there's a lot of variability in how cytology is done, from probably comparing the West Coast to the East Coast. We do a lot of pleural fluid on the West Coast, and so we're comfortable with mesothelial proliferations. So the two situations that you're going to get with a mesothelial proliferation that your cytologist is going to come across, and when you phone them up and you say, what does it show? Is it malignant or not? And they're going to tell you one of two things. Either it's clearly malignant, and that we can see malignant cells are present, and we now need to do more work to see if these are mesothelial or adenocarcinoma. And this is the example of what we're seeing in this circumstance. So we've got these large, really tightly cohesive sheets, more than 50 cells in each ball, or you've got cells that are overtly malignant. These are mesothelial cells. They are big, they're irregular, they're mitotic activity, they're nasty. So we can tell you that it's malignant, but we can't go further. The second category we're going to tell you is that these cells are present. We've got mesothelial cells. They look a little bit jazzed up, but we can't tell if they're reactive and benign or whether they're mesothelioma. And that sounds like a strange situation, but that's the reality of the second category. So the groups here, they're smaller, the cells are bland, they're not necessarily overtly malignant. The groups, instead of being really tightly cohesive and balled up, are more loosely cohesive and falling apart. So what do you do with those two circumstances? With malignant, we know we've got enough material, we can move on. We just have to decide, is this a metastatic glandular process or is this mesothelioma? And we use our immunohistochemical markers to determine the origin. All the morphological signs of mesothelioma also apply to adenocarcinoma. We can make an educated guess based on what the morphology is, but over time with experience, you can guarantee that you can swear something black and blue is mesothelial and it end up being adenocarcinoma or vice versa. So to be accurate, you need that ancillary testing. Unfortunately, there's no specific mesothelial marker on its own. There's no one marker that says this is mesothelial, but we use a combination of markers to try and make sure we're being accurate. And then in that second circumstance where you've got an atypical population, the first step is to prove that these cells are mesothelial. And then we use immunohistochemical markers of malignancy to prove that they're malignant as opposed to a reactive process. And so those are EMA, BAP1, or MTAP. If these are all normal, keep in mind this still could be meso. We just can't diagnose it. Because if you have a low-grade proliferation with no immunohistochemical markers of malignancy, doesn't mean those cells are benign. It does mean that we can't diagnose them. And that is probably the only circumstance where you might get an indeterminate pleural fluid rather than a negative malignancy sort of circumstance, because we can't differentiate accurately between a reactive proliferative process or a neoplasm. So why is mesothelioma so hard? It seems like, cancer should be cancer. And, in your experience with lung cancers, it generally tends to be that you see these ugly cells. We look down the microscope, they look horrible, yuck, cancer. So mesothelioma is a bland malignancy. So the mesothelial cells can look essentially like normal mesothelial cells, but they actually represent an underlying malignant process. In the contrast, reactive mesothelial cells can be really wild and they can look like the worst cancer you've ever seen, but they actually represent a really benign process. And that's why the importance of those two categories and stepping back and using those ancillary tests is so important. Reactive mesothelial cells can be caused, of course, by anything from radiation, heart failure, instrumentation, but the two big ones that we pay attention to are probably radiation and other cancers. The worst looking mesothelial cells I've ever seen have been those reacting to a metastatic cancer or post-radiation. So I've not uncommonly seen where you either get small cell met in the pleural fluid alongside a very florid reactive mesothelial proliferation, or you get a small volume metastatic carcinoma, and then you get a red herring of a really florid mesothelial process. And chemorads does a similar thing. So that's where we step into uncertainty. It's not your friend as long as you understand why we're saying these things and what the drawbacks are. So if you understand that reactive mesothelial cells can look really bad and also that malignant mesothelial cells can look not so bad, you start to understand why the uncertainty goes hand in hand. So why do we get uncertainty? In atypical, sometimes you get uncertainty, and this can depend by laboratory and experience, of course. Some people unfortunately use it as a waste basket. Hopefully most people don't, but it can be a common category for people to use if they're a little bit inexperienced or uncertain, because then you end up with a category of ease where you can not send a patient off into the distance, but also maintain some safety. But it should always be accompanied by a comment with a guide what to do next. These are atypical cells. we need more material. These are atypical cells. Please refer them to this sort of specialist. There should always be some sort of guidance. And if it's not forthcoming, ask. Make sure you have clarity from your pathologist and say, what is holding you back? What can I do next to make us get there? And then the other one is indeterminate. I always see follow-up forms and they say previous biopsy non-diagnostic, and I look on the system, it was indeterminate. It's not the same thing. And I see this interchangeably used. So understanding your report and understanding what we're conveying by indeterminate is really important. What we're saying is there's a process here. It could be reactive or it could be neoplastic, and we need something else to help us figure that out. For example, and hopefully people can pipe up. I don't know if everyone's muted, but little audience participation. You're in an EBUS FNA, you've got a lymph node station 7, there's a history of colon cancer, you've got matted nodes, it's PET avid, on-site cytology shows non-necrotizing granulomas. What's the diagnosis? It's non-diagnostic. So the thing I really wanted to hammer home is that across specimens, across pleural cytology, it doesn't matter what you're seeing. If it doesn't fit, it's not diagnostic. That's not sarcoidosis just because you see non-necrotizing granulomas, just as the same as if you see atypical mesothelial cells in the pleural fluid, it's not necessarily mesothelioma. So, you know, pleural fluid, and I'm sorry I haven't been able to cover absolutely everything, and I'm not sure what areas people always want to know more about, you know, lists of differentials, we can look at books, but I think if we talk about communicating and both way communication, we'll understand each other a lot better. Remember, indeterminate is not non-diagnostic. Know your categories and what we're trying to tell you with them. Beware of the hidden curriculum. Understand things, you know, might be more complicated. If someone has just written negative for malignancy, lymphocytosis, that might be just something that you discharge a patient. But the hidden curriculum here is if you've got someone with repeated unexplained lymphocytoses, you need to be investigating this further because the sarcomatoid mesothelioma is still on the differential. Hopefully your pathologist will be flagging this for you, but if they don't, understanding this hidden curriculum is important. Another example is eosinophilia. You know, the most common cause I see of an eosinophilic effusion is actually just repeated pleural taps. So, you know, I can give you lists of these sorts of things, but understanding these things sometimes takes a bit of experience. And then exfoliative versus biopsy cytology. I think people, once they realize that we're looking for different parameters and we're giving different outcomes, if you understand why we're not calling a fluid benign and why we're calling something with heaps of material in it non-diagnostic, I think you'll go a long way to starting to integrate these cytology reports into your practice. Great. Do you have any questions?
Great. Thank you, Celia. I think we all have experienced a lot of these dilemmas before. Can I just encourage the audience, forgot to mention at the beginning that if you have any questions, please put it on chat and then we'll go through them as much as we can. I'll kickstart the process. So Celia, how much variability is it acceptable amongst the cytologists? So some people's indeterminate, is it somebody else atypical and so on and so forth?
It is. I think the difference between what is acceptable, I would say a very narrow range of variability is acceptable. What you're going to get in practice is a very broad range of variability. So particularly, you know, in Australia, there's a quite large divide, I think, east-west in terms of cytological practice. So, you know, you're going to get lots of variability. I think knowing your cytologist, it's a little bit like anything. You wouldn't send your partner to a surgeon that you don't know if they're any good or not. You wouldn't send your specimen to a pathologist. So get to know your pathologist, call them, not too much, they'll stop answering your calls, but get to know them, get to understand what their level of certainty is, what their level of experience is. But I mean, unfortunately, like in anything, there's going to be a broad range. But what you can do is if you are getting sort of insufficient answers, you can ask them to show someone else. Have they referred it to someone else? Because, you know, the thing about pathology, the beauty of it is unlike a patient, you can hand the case on very easily and they can seek outside opinion from people who have maybe a little bit more experience if needed. So If you pay attention to your report and you're like, oh, this is indeterminate and I've read this and they're not quite getting there, have they considered asking someone with more experience? Are they the most experienced? Therefore, I'm going to believe this. Atypical, have they mentioned that they tried to do anything on the cell block? And if they haven't, maybe call them and say, was there nothing in the cell block? Do you need more material? Or do I need to do another biopsy?
Sure. Now, not surprisingly, the first question we have on chat was, what is the minimal volume you would need, or what is the ideal volume you would want? There's a lot of complaints from clinicians to say that there's no point of sending you a lot of fluid because the laboratory will just throw it away after a certain volume anyway. You want to clarify that for us?
We don't throw anything away until the report is finalized. So sometimes that can be 2 weeks at a time, but no, we don't get rid of anything until the report's finalized. We don't get rid of the slides ever. So, these things remain. But yeah, no, the minimum volume, look, all of the papers basically say that a minimum volume of 50 to 60 mils will give you answers the majority of the time. We have great success with that. I think the problem is there tends to be a big cutoff. Obviously, if you only get 20 mils, please send it. We will take it. Similarly, if you get 3 liters, we don't mind being sent it. We're not going to get angry and say, what do you want us to do with this? We're going to process it and be glad, because we've gotten enough specimens where someone comes in with massive ascites and a 2 mil specimen that we will definitely not be angry the other way.
Yeah.
We won't use all of it necessarily, but yeah, if you can send us like 50 to 60 mils, some of the other studies tend to say that if you get 100 mils, basically that's the cutoff where things don't improve. So if you get 100 mils versus 300 mils, you're not necessarily going to get a change in your result from 100 to 300. In this day and age, ancillary studies are king. We can do molecular studies on the cell block. So if you do send more, the only thing I will say is please don't send 2 to 3 mils if you've got more than that.
Yeah.
It's very hard for us to get a good result.
Sure. Another 2 questions, all about processing. Does it make a big difference if we use those preservative bottles or adding heparin to the cytology samples, or should we send it fresh? And alongside that, how quickly does it need to go to the lab before it degrades?
Yep. So 2 things. If we would prefer them sent in the specimen collection bottles. They do have stuff in it to start to preserve the cells. If you use that, though, keep in mind that that can't be sent for microbiology afterwards. So you do separately need to keep a microbiology jar. And then the second thing is, as soon as possible, cells degrade very rapidly. So, in tissue specimens, in biopsies of, histology, we know that actually within 10 minutes of not being in formalin or fixative, cells start to degrade. And in cytology, it's the same. So the quicker you can get it in, the absolute better. But if you put it in a jar with prefixative, then that really helps the process a lot. But yeah, beware that you can't send it to micro afterwards.
Okay. I think all hospitals have pathologists. Can you clarify for us, do you need special training to become a cytologist, or is it just some special interest that you develop on your way?
So not in Australia. So part of the anatomical pathology program in Australia, everyone does cytology. So we have a set of exams. Some of them are histology exams and some of them are separate cytology exams. You also need to report a certain number of cases and, keep those up for the college to demonstrate that you can come. And then following that, if you really want to do cytology, it depends on the centre. Most people will do fellowships if they've gone to proper centres. And so hopefully asking that person whether they've done a fellowship and then who that fellowship is under will become important to knowing more about your cytologist. And then what centre they come from, because, obviously a tertiary centre will have a lot more experience.
A lot of people will say that their centres aren't as lucky as we are to have someone like you. And if you have no pathologist with a special chest or pleural interest, how easy or difficult is it to go and get a second opinion with your samples?
I would say it's relatively easy in the sense that we can move slides very easily. It will have a delay depending on how quickly that person packs up the slides and sends it down the road and how far away. If you're 2 hours outside of Melbourne and you have to send the slides to Melbourne, the transit delays and things like that. I would encourage people to start considering alternative things like, Microsoft Teams. I've got a camera on this microscope here. A lot of people have access to cameras. You can show each other cases in those sorts of ways. So yeah, it's certainly getting easier and easier in the digital age. It can give you a time delay. I think the problem is depending on the relationship with the pathologist. If they send it down the road and then it doesn't get registered and they don't tell the person who it's going to pick it up, or the urgency. So I think those are the things. Can you send it to someone down the road? Can you tell them it's urgent? Can they give us a call immediately?
Yeah. Is AI going to replace the cytologist?
I wish. I think no, I love my job, but I think AI is definitely going to do important things, but I don't think it's going to replace cytology because it's still subjective. I think, a lot of people think you look down a microscope and you see one thing or you see another thing, and that's just not the reality. Like I say, sometimes you do see just outgoing cancer down the microscope, and AI is probably going to be very good at doing that. But we also have a lot of gray zone in between, and they're the ones that are really going to, machine learning is not going to be able to fix. Hopefully what machine learning will be able to do is remove the boring or laborious things that we do, like counting mitoses or finding things. Also, AI is really being developed as a second check. There's a lot of work in particularly prostate biopsies, which shows that AI can run second checks and make sure we have a lower rate of error. So hopefully it'll be mostly reducing error rather than replacement.
And this is only something that I only just realized very recently, that a lot of hospitals, or not every hospital, would actually look at all the biopsies we have taken. And a lot of times they only cut certain number of slides from the paraffin block. Is that true?
Not for biopsies, but certainly for excisions. So biopsy specimens, if they're core biopsies, we submit all of them and we look at them often at multiple levels. If you excise a lung, obviously there's no way to process a whole lung in 5-micron sections. So what we do is we gross the specimen, we take the lymph nodes from the hilum, we take the resection margin, we sample the tumor, and we put them in little blocks at 3 to 5 millimeter sections, and then we cut 5-micron sections from that. So yeah, a whole lung will not be processed, but a whole biopsy that's a small biopsy will be.
Okay. Well, I think we are at 2:30, so 2:30 of my time. So if there's no other urgent question on chat, we'd like to thank Celia. And I think this has been very useful, and we have always encouraged our trainees to spend a lot of time with our pathologists, and maybe we need to bring Celia back and actually show us how to read the slides so that we can learn to communicate with the pathologist better. So thank you again, Celia. And just to remind everyone that the recordings are placed on YouTube nowadays. If you just go on YouTube and search the Australasian Pleural Seminars, you can see all the previous talks as well. And I look forward to seeing you in July, in the first Wednesday, as always. Thank you. Bye-bye.
Thanks, Gary.